Chapter 6 Mood Disorders. Monoamine neurotransmitter systems are hypothetically linked to the biological basis of mood disorders, namely depression, mania, or both. The three principal monoamine neurotransmitters are norepinephrine, serotonin, and dopamine. In this chapter, the plan is to deconstruct each mood disorder into its component symptoms and matching each of those symptoms to a malfunctioning brain circuit, each regulated by one or more of these monoamine neurotransmitters. Description of mood disorders. Mood disorders are also called affective disorders, since affect is the external display of mood, an emotion that is felt externally. And depression and mania are often seen as the opposite ends of this affective or mood spectrum. Classically, mania and depression are considered to be poles apart, thus generating the term unipolar or bipolar if the patient has only depression or symptoms of both. Depression and mania may also occur simultaneously, called a mixed mood state. And mania may occur in a lesser degree known as hypomania, or switch so fast between mania and depression that it is called rapid cycling. Mood disorders can be usefully visualized, mapped onto a mood chart, in which the mood ranges from hypomania to mania at the top, euthymia or normal mood in the middle, to dysthymia and depression at the bottom. Now, dysthymia is interesting. It is a less severe but long-lasting form of depression. And patients with major depressive episodes who have poor inter-episodic recovery only to the level of dysthymia followed by another episode of major depression are sometimes called to have double depression, alternating between major depression and dysthymia but not remitting. Coming on to bipolar 1 disorder. It's full-blown manic episodes or mixed episodes of mania plus depression, or manic episodes followed by depressive episode. And when mania occurs at least 4 times a year, it is called rapid cycling mania. Or can also have rapid switches from mania to depression and back at least 4 times a year, that is having at least 4 distinct mood episodes. Coming on to bipolar 2 disorder. It is defined as at least one hypomanic episode that follows a depressive episode. Cyclothymic disorder is characterized by mood swings that are not as severe as full mania or full depression, but still wax and wane above and below the boundaries of normal mood. And there may be lesser degree of variation from normal mood that are stable and persistent, including both depressive temperament that is below normal mood but not a mood disorder, and hyperthymic temperament above normal mood but also not a mood disorder. And temperaments are personality styles of responding to environmental stimuli that can be heritable patterns present early in the life and persisting throughout a lifetime. Now let's discuss the bipolar spectrum. Mood disorders not well described by the above categories previously would have fallen into not otherwise specified or NOS, but now such patients are seen as belonging in general to the bipolar spectrum, and in particular to one of several additional descriptive categories that have been proposed by experts such as Hagop Akiskal. The first one being bipolar 1/4 or 0.25. This is an unstable form of unipolar depression that responds sometimes rapidly but in an unsustainable manner to antidepressants, the latter sometimes called antidepressant pop-out. They have unstable mood but not a formal bipolar disorder, yet can be benefited from mood stabilizing treatments added to robust antidepressant treatments. Coming on to bipolar 1/2 or 0.5 and schizoaffective disorders, sometimes also known as schizobipolar disorder. Experts have debated whether psychotic disorders such as schizophrenia, as Kraepelin has proposed, with chronic unremitting illness with poor outcome and decline in function, are dichotomous from mood disorders, usually cyclical illnesses with better outcome and good restoration of function between episodes, or are part of a continuous disease spectrum from mood to psychosis. Proponents of the dichotomous model point out that treatments for schiz differ from those of bipolar disorder, since lithium is rarely helpful and anticonvulsive mood stabilizers have limited efficacy in psychotic symptoms, perhaps only as augmenting agents. On the other hand, the continuum disease model proposes that psychotic and mood disorders are both manifestations of one complex set of disorders that is expressed across the spectrum, with schizophrenia at one end and at the other end bipolar disorder, with schizoaffective disorder being in the middle. Now, modern genomics suggests that spectrum is not a single disease, but a complex of hundreds, if not thousands of different diseases with overlapping genetics, epigenetics, and biomarkers, as well as overlapping clinical symptoms and functional outcomes. Proponents of this claim, treatments of schiz overlap greatly now with those of bipolar disorder, since second-generation atypical antipsychotics are effective in positive symptoms of schiz as well as in psychotic mania and psychotic depression. These are also effective in non-psychotic mania as well as bipolar and unipolar depression, and seem to be effective in the spectrum of symptoms for schizoaffective disorders. And interestingly, failure to give mood stabilizing medication may lead to suboptimal symptom relief in patients with psychosis, as prominent or eye-catching psychotic symptoms mask or distract clinicians from seeing underlying and perhaps more subtle mood symptoms. And the debate rages on. Bipolar 1.5 or 1.5. It is protracted or recurrent hypomania without depression. Eventually, such patients will often develop a major depressive episode, and the diagnosis will then change to bipolar 2 disorder. Bipolar 2.5 or 2.5. This designation is for cyclothymic patients who develop major depressive episodes. Cyclothymics are often called moody, and treatment of their major depressive episodes with antidepressant monotherapy may actually cause increased mood cycling or even induction of a full manic episode. Coming on to bipolar 3. This is manic or hypomanic episode on an antidepressant, that is, substance-induced mood disorder. Bipolar 3.5 or 3.5. It is bipolar disorder associated with substance abuse, and as can be expected, combination of mood disorder with substance abuse is a formula for chaos. Bipolar 4. It is depressive episodes with pre-existing hyperthymic temperament. As we know, hyperthymics are often sunny, optimistic, high output, successful individuals with stable temperaments for years, but then might suddenly collapse into a severe depression. Such patients may respond best to mood stabilizers. Bipolar 5. This is depression with mixed hypomania. Generally have a worst outcome, as there are more mood episodes, more work impairment, and more likely to have family members with mania or other bipolar disorders, as well as early onset depression, and it is more important to emphasize overactivity rather than just mood elevation, and a duration of only 2 days as opposed to 4 days required in most diagnostic systems in hypomania. Other related conditions include both full mania diagnostic criteria and full depression diagnostic criteria. The other one is depression with only few hypomanic symptoms, then full mania with only few depressive symptoms, also called dysphoric mania, and some symptoms of both mania and depression but not diagnostic of either. Patients with mixed states may be particularly vulnerable to induction of activation, agitation, rapid cycling, dysphoria, hypomania, mania, and suicidality when treated with antidepressant, particularly without concomitant use of mood stabilizers or an atypical antipsychotic. The mixed states are summarized in this table. Coming on to bipolar 6. It is bipolarity in the setting of dementia, where it can be incorrectly attributed to the behavioral symptoms of dementia rather than recognized and treated as a comorbid mood state with mood stabilizers and even with atypical antipsychotics. So what is the takeaway from all this information? Not all patients with depressions have major depressive disorder requiring treatment with antidepressant monotherapy, and there are many states of mood disorders within the bipolar spectrum beyond just bipolar 1 and bipolar 2. Can unipolar depression be distinguished from bipolar depression? Up to half of the patients once considered to have unipolar depression are now considered to have bipolar spectrum disorder, as can be seen from this shift in paradigm. Antidepressant treatments of unrecognized bipolar patients may not only increase mood cycling and mixed states, but also conversion to hypomania and mania as mentioned above, but may also contribute to increase in suicidality in young patients. Thus, it becomes important to distinguish unipolar from bipolar depression. Thus, you should know who's your daddy, which means what is your family history, since first-degree relatives with bipolar spectrum disorder can give a strong hint that the patient also has a bipolar spectrum disorder rather than unipolar depression. And the following questions might help to clear family history. Any mood disorders, psychiatric hospitalizations, suicides, anyone who took lithium, mood stabilizers, antipsychotics or antidepressants, anyone who has received ECT. The next set of questions can be summarized as where is your mama? Which means I need to get additional history from someone else close to you, since patients tend to underreport their manic symptoms. Some hints can even come from current symptoms to suggest a bipolar spectrum depression, such as more time sleeping, overeating, comorbid anxiety, motor retardation, mood lability, psychotic symptoms, or even suicidal thoughts. Hints can also come from the course of the untreated illness prior to the current symptoms, such as early age of onset, high frequency of depressive symptoms, high proportion of time spent ill, and acute abatement or onset symptoms. And prior response to antidepressants that suggest bipolar depression can be multiple antidepressant failures, rapid recovery, and activating side effects such as insomnia, agitation, or anxiety. Are mood disorders progressive? Chronic and widespread undertreatment of unipolar depression allows residual symptoms to persist and relapses and reoccurrences to occur. This can result first in more rapidly recurring episodes of major depression, then in poor inter-episodic recovery, then progression to a bipolar spectrum condition, and finally to treatment resistance. And thus recognition and treatment of both unipolar and bipolar depressions causing all symptoms to remit for long periods of time might prevent progression to more difficult states. Thus, practitioners must decide whether to commit sins of omission and be conservative with diagnosis of bipolar spectrum disorder and err on the side of undertreatment of mood disorders, or commit sins of commission and overdiagnose and overtreat symptoms in the hope that this will prevent disease progression. Neurotransmitters and circuits in mood disorders. Three principal neurotransmitters have long been implicated in both the pathophysiology and treatment of mood disorders, sometimes called the monoamine neurotransmitter system, and these include norepinephrine, dopamine, and serotonin. Let's first discuss non-adrenergic neurons. As the name suggests, it utilizes norepinephrine as its neurotransmitter. It is synthesized from the precursor amino acid tyrosine, transported into the nervous system from the blood by means of active transport pump. Once inside, it is acted upon by three enzymes in sequence. First, tyrosine hydroxylase. It is the rate-limiting and the most important enzyme in the regulation of any synthesis, which converts tyrosine to dopa. The second enzyme to act is dopa decarboxylase, which converts dopa into dopamine. In the third and final step, dopamine beta hydroxylase converts dopamine into norepinephrine. Norepinephrine action is terminated by two catabolic enzymes. The first is monoamine oxidase A or B, which is located in mitochondria in the presynaptic neurons. And the second one is catechol methyltransferase, which is thought to be located largely outside the presynaptic nerve terminals. The termination of action can also be by a transport pump that removes any from acting in the synapse without destroying it, and is sometimes called the any transporter or net. Once inside the presynaptic nerve terminals, it can either be stored for further use or destroyed by the aforementioned enzymes. It is located on the presynaptic noradrenergic nerve terminals as part of the presynaptic machinery of the neuron, where it acts as a vacuum cleaner. The noradrenergic neuron is regulated by a multiplicity of receptors. The aforementioned net is one type of receptor, as is the vesicular monoamine transporter, that transport any in the cytoplasm of presynaptic neurons into storage vesicles. Now, any receptors are classified as alpha 1, alpha 2 ABC, or as beta 1, 2, 3. All can be postsynaptic, but only alpha 2 receptors can act as presynaptic autoreceptors and regulate norepinephrine release, and are located both on the axon terminal and the cell body near the dendrites. And as we have studied earlier, these are known as somatodendritic alpha 2 receptors. When these presynaptic receptors recognized any, they turn off its further release and act as brake cables for the any neurons, which is also known as negative feedback regulatory signal. Interestingly, drugs that antagonize this receptor will have the effect of cutting the brake cable, thus enhancing release of any. Similarly, the postsynaptic receptors convert their occupancy by norepinephrine into physiological functions, and ultimately into changes in signal transduction and gene expression in the postsynaptic neuron. Monoamine interactions, any regulation of 5-HT. The three monoamines can regulate their own release. Dopamine regulates dopamine neurons via D2 receptors, and serotonin regulates serotonin neurons via 5-HT1A and 5-HT1BD presynaptic receptors, and also via 5-HT3 and 7 postsynaptic receptors. Interestingly, these three monoamine interacts to regulate each other. For example, serotonin regulates dopamine via 5-HT1A, 2C and 2A receptors, and it regulates norepinephrine release via 5-HT2C receptors. Serotonin also regulates dopamine and norepinephrine via 5-HT3 receptors. NE reciprocally regulates 5-HT neurons via both alpha 1 and alpha 2 receptors. Alpha 1 receptors acts as accelerators and alpha 2 receptors as brake on the 5-HT release. Any neurons from the locus coeruleus travel a short distance to the midbrain raphe, and there they release NE onto postsynaptic alpha 1 receptors on 5-HT neuronal cell bodies. This directly stimulates 5-HT neurons and acts as accelerator for 5-HT release. NE neurons also innervate the axon terminals of 5-HT neurons. Here, NE is released directly onto postsynaptic alpha-2 receptors that inhibit 5-HT neurons, acting as brakes on 5-HT, thus inhibiting 5-HT release. Interestingly, which action of NE predominates will depend upon which end of the 5-HT neuron receives more noradrenergic input at any given time. As we know, there are many brain areas where 5-HT, NE and DA projections overlap. Monoamine hypothesis of depression. The classic theory of biological etiology of depression hypothesizes that depression is due to a deficiency of monoamine neurotransmitters and mania may be the opposite. The entire monoaminergic neurotransmitter system of all three monoamines may be malfunctioning in various brain circuits with different neurotransmitters involved, depending upon the symptom profile of the patient. But any direct evidence for monoamine hypothesis is still largely lacking. That is to identify the predicted deficiency of the monoamine neurotransmitters in depression and an excess in mania. This effort to date has unfortunately yielded mixed and sometimes confusing results. The monoamine receptor hypothesis and gene expression. And because of this aforementioned lack of direct evidence, the focus of hypothesis has shifted from monoamine neurotransmitters to their receptors and the downstream molecular events that these receptors trigger, including the regulation of gene expression and the role of growth factors. There is also great interest in the influence of nature and nurture on brain circuits, especially what happens when epigenetic changes from stressful life experiences are combined with the inheritance of various risk genes. The neurotransmitter receptor hypothesis posits that abnormality in the receptors of monoamine leads to depression. Thus, depletion of neurotransmitters causes compensatory upregulation of postsynaptic neurotransmitter receptors. And postmortem studies do consistently show increased number of serotonin 2 receptors in the frontal cortex of patients who committed suicide. There may be a deficiency in the downstream signal transduction of the monoamine neurotransmitter, as well as its postsynaptic neuron that is occurring in the presence of normal amounts of neurotransmitters and receptor. Thus, the problem in depression could lie within the molecular events distal to the receptor, in the signal transduction cascade system, and in the appropriate gene expression. Now let's discuss stress, BDNF and brain atrophy in depression. One candidate mechanism in depression is the target gene for BDNF. It sustains the vitality of neurons, but under stress, the gene for BDNF may be repressed. And stress can lower 5-HT levels and then acutely increase, then chronically deplete both NE and DA. Coupled with deficient BDNF, this may lead to atrophy and possible apoptosis of vulnerable neurons in the hippocampus and other brain areas such as prefrontal cortex. Some of this neuronal loss may be reversible by antidepressants that can increase BDNF and other trophic factors and potentially restore lost synapses. Neurons from hippocampal area and amygdala normally suppresses HPA axis, but stress causes hippocampal and amygdala neurons to atrophy, and thus it could lead to overactivity of the HPA axis. Interestingly, in depression, abnormalities of the HPA axis has long been reported, including elevated glucocorticoid levels and insensitivity of HPA axis to feedback inhibition. And in return, glucocorticoids at high levels could even be toxic to neurons and may contribute to their atrophy. Novel antidepressant treatments are in testing that target CRF1, vasopressin 1b and glucocorticoid receptors to halt and even reverse these HPA abnormalities in depression and other stress-related psychiatric illnesses. Now let's discuss stress and the environment. Certain amount of stress loads on bones, muscles and brain is necessary for growth and optimal functioning and can even be associated with developing resilience to future stressors. However, certain types of stress such as child abuse can sensitize brain circuits and render them vulnerable rather than resilient to future stressors. For example, in women abused as children, depression can be found up to 4 times more often than in never abused women. And the likely explanation is that epigenetic changes caused by environmental stress create relatively permanent molecular alterations in the brain circuit at the time of child abuse that do not cause depression per se but make brain circuits vulnerable to future stresses. Stress and vulnerability genes. Can you be born fearful? Modern theories states that mood disorders are caused by a conspiracy among many vulnerable genes and many environmental stresses, leading to breakdown of information processing in specific brain circuits. Interestingly, there is a great overlap between the genes that are thought to be vulnerability genes for SCHIZ and those that are thought to be vulnerability genes for bipolar disorder. One of these genes for depression is the gene coding for the serotonin transmitter or SERT. The type of SERT determines in part whether your amygdala is more likely to overreact to fearful faces or whether you are more likely to develop depression when exposed to multiple life stressors, and how likely your depression is to respond to SSRI or SNRI treatments, or whether you can even tolerate them. Specifically, the S variant of this gene can cause excessive reaction of the amygdala and more likely to develop an affective disorder when exposed to multiple life stressors, and may even have more hippocampal atrophy and more cognitive symptoms and less responsiveness or tolerance to SSRI or SNRI treatments. These genes also can alter the efficiency of effective information processing by your amygdala and consequently your risk of developing major depression if you are experiencing multiple life stressors. On the other hand, the L genotype of SERT is more resilient with less amygdala activity to fearful faces and is less likely to break down during stress and is more likely to respond or tolerate SSRI or SNRI treatments. Thus, perhaps one is not born fearful but born vulnerable or resilient to developing major depression, or hippocampal atrophy and hyperactivity of HPA axis in depression. In situations of chronic stress, excessive glucocorticoid release may eventually cause hippocampal atrophy. And as previously stated, hippocampus inhibits the HPA axis, and atrophy in this region may lead to chronic activation of HPA axis, which may increase risk of developing psychiatric illnesses. Development of stress resilience. In a healthy individual, stress can cause a temporary activation of circuits, which is resolved when the stressor is removed, and the circuit is provoked yet able to compensate for the effects of the stressor. And by its ability to process the information load from the environment, it can avoid producing symptoms. When the stressor is withdrawn, the circuit returns to baseline functioning. It is now believed that short-term stress may even develop resilience to stress. Development of stress sensitization. Prolonged activation of circuits due to repeated exposure to stressors can lead to a condition known as stress sensitization, in which the circuits not only become overly activated but remain overly activated even when the stressor is withdrawn. But the individual exhibits no symptoms because these circuits can somehow still compensate for the additional load. But risk of developing psychiatric symptoms is increased. And this constitutes a pre-symptomatic state for some psychiatric symptoms. Interestingly, this state might be detectable with functional brain scans, but not from psychiatric interviews. The progression from stress sensitization to depression. As previously stated, overwhelming or chronic stress, for example in child abuse, may lead to stress-sensitized circuits that may become activated in the absence of a stressor. Symptoms and circuits in depression. As we know, the symptoms of depression according to DSM-5 are either a depressed mood or loss of interest, and at least 4 of the following: weight or appetite changes, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue, feeling of guilt or worthlessness, executive dysfunction, and suicidal ideation. Interestingly, each symptom is hypothetically associated with inefficient information processing in various brain circuits, with different symptoms topographically located in specific brain regions. For example, DLPFC deals with concentration, interest or pleasure, and psychomotor fatigue. VMPFC deals with guilt, suicidality, worthlessness, and mood. Nucleus accumbens is the seat of pleasure, interest, fatigue, and energy. Amygdala also deals with guilt, suicidality, worthlessness, and mood. Striatum with psychomotor and physical fatigue. Hippocampus with sleep and appetite. Spinal cord also deals with physical fatigue. And cerebellum with psychomotor symptoms. The mood-related symptoms of depression can be categorized as having either too little positive affect or too much of negative affect. Symptoms related to reduced positive affect include a depressed mood, loss of happiness, interest or pleasure, loss of energy or enthusiasm, a decreased alertness, and decreased self-confidence. And reduced positive affect may be hypothetically related to dopaminergic dysfunction with a possible role of noradrenergic dysfunction as well. Increased negative effects includes depressed mood, guilt, disgust, fear, anxiety, hostility, irritability, and loneliness. And this increased negative effect may be linked hypothetically to serotonergic dysfunction and perhaps to noradrenergic dysfunction. The diffuse dopamine dysfunction in this system drives predominantly the reduction of positive effect, and the diffused serotonin dysfunction predominantly drives the increase in negative effect. and norepinephrine dysfunction is being involved in both. Systems and circuits in mania. Inefficient functioning in these circuits in mania may be more accurately portrayed as out of tune, rather than simply excessive or deficient, especially since some patients can simultaneously have both manic and depressed symptoms. DLPFC is thought to be involved in racing thoughts, grandiosity, distractibility, talkativeness, and pressure speech. Basal forebrain in decreased sleep or excessive arousal. VMPFC in elevated mood, risks, grandiosity, talkativeness, pressure speech, and racing thoughts. Amygdala in mood, nucleus accumbens in racing thoughts, goal-directed activity and grandiosity. Striatum in increased motor activity and agitation, while thalamus and hypothalamus deals with decreased sleep or increased arousal. Neuroimaging in mood disorders. Progress is being made in mapping inefficient information processing in various circuits in mood disorders. As previously stated, in depression, the DLPFC may have reduced activity, and the amygdala associated with various emotional symptoms including depressed mood may have increased activity. Depressed patients show that their neuronal circuits at the level of amygdala are overactive to induce sadness but underreactive to induce happiness, while manic patients shows that they fail to appropriately activate a brain region in a test that requires them to suppress a response.